here today amongst all of you. And I thank Dr. Gupta and Dr. Lokesh for inviting me. And I've really enjoyed my short stint at Rishikesh. I wish to come back again and spend longer time with you here. Before I start, I would like to ask how many of you, any pediatrician in this audience or anybody who's doing pediatric sleep? So almost none. Okay, so I would like to start by asking how many of you slept more than 8 hours last night? 1, 2. Wow. And how many slept between 6 to 8 hours? And that's a good number. And how many slept less than 6 hours? So we actually have a good volume which slept 6 to 8 hours. So at least we practice what we preach. That's a good starting point here. Okay, so I'm going to talk to you about an 8-year-old girl who resists going to bed. All right. Though you may not be practicing pediatric sleep, but I'm sure many of you have children or maybe relatives who have children, and you will associate with this presentation because you will be seeing children with these kind of problems. Okay, so healthy sleep is defined as a sleep which you fall asleep very quickly. So typically 15 to 20 minutes is the time you should take. That's your sleep latency. You should stay asleep through the night and no troublesome night awakenings. And you should rise, not being pushed out of bed because the alarm was buzzing and you pushed it to snooze mode 4 times. But you should rise without much trouble each morning, and you should have a refreshed night's sleep and not feel drowsy, especially not during my lecture through the day. So that is what you describe as a healthy sleep. Okay. It is also important that the duration of the sleep is important, and more so for pediatrics because the duration of sleep changes as the child grows older. So infants, you will know that they would sleep for a very long period of time. So 4 to 12 months in a child who's between the age of 4 to 12 months would sleep for 12 to 16 hours in a day. But and children between 1 to 2 will sleep at a range of 11 to 14 hours. 3 to 5 years, 10 to 13 hours, and children between 6 to 12, 9 to 12 hours a day. And when you get into adolescent age group, your requirement of sleep goes up a bit and it becomes 8 to 10 hours. And when you're an adult, it is about 7 hours plus. But having said that this is the duration of sleep, this is kind of a data which is generated more on like a survey-based thing, and there is nothing proven about it. And we know that there are cross-cultural differences in the requirement of sleep. So, and it is seen that people from the Asian, part of the world, the Asian continent, have significantly less sleep. They sleep later, their total sleep time is lesser. And there is an increased parental perception of sleep problems in this part of the world. And of course, we know we co-share. It is a very, kind of a social thing that in India, you will have children sleeping with the parents till a very late age. So this is so much of a cultural thing that in the Asian community, we sleep less. I don't think we are anyway inferior in cognitive skills to anyone in the Western world, but we are doing with less sleep. So there are a lot of cross-cultural differences in the requirement of sleep. Okay, and I would like to to highlight what is normal awakening in children, because unless we know what's normal, this is not true for adults. Therefore, I would like to highlight to this audience because you are not doing pediatric sleep. So in an infant, in the first year of life, so 2 to 6 times per night, a baby can get up, especially in the first 6 months of life. So every 90 to 120 minutes, a baby can get up. This is a brief awakening. And most of the time, after the age of 6 to 8 months, the baby can actually go back to sleep quickly, even without a parental intervention. So these are basically called awakenings and not arousals. But what do parents interpret it as? Parents interpret it as that the baby needs something. So they would either rock the baby, they would feed the baby, and then this becomes a sleep association. And then the baby looks forward to this association, and we actually convert this awakening to an arousal, right? So, so if the awakening is prolonged and the baby cannot go back to sleep on his own, this is problematic. It disturbs not only the pediatric sleep, but also the parent sleep. And you have working moms, so if they have to keep getting up every 2 hours or 3 hours in the night to nurse the baby or to rock the baby to go to sleep, it is known to cause even depression in parents or working parents. And I've had parents who have connected with me, 2 years we have not slept a wink, the baby doesn't sleep, but it is the wrong understanding of the baby's awakening, which gets associated with a prop, which could be either feeding or rocking, which results in this phenomena. So between age 4 to 6 months, the baby can have long stretches of sleep up to 4 to 8 hours. Below the age of 3 months, yes, the baby has to get up for a feed. But after the age of 4 to 6 months, the range of 4 to 6 months, the baby can actually sleep for 4 to 8 hours. More than 6 months, the baby can actually sleep for 8 hours at a stretch, even without taking a feed. And after 12 months, the baby should be able to sleep like an adult through the night without a feed. Now, this understanding has to be impressed upon the parents because they continue to feed the baby through the night and they do not understand that the baby can now actually sleep without a problem. Okay. So what do we define insomnia as? It is difficulty in either falling or staying asleep, or resistance to go to bed, or difficulty in sleeping without parental presence or support. So earlier, the definition before 2013 did not include parental presence or support, but it has now become inclusive across all ages to include the pediatric age group. So therefore, the parental support or presence has been included. Along with difficulty in falling asleep, daytime impairment in attention or behavior problems, impairment in academic or family functioning, and an age-appropriate opportunity for sleep. So this is the definition of insomnia in totality. And chronic insomnia is sleep disturbance and daytime impairment for at least 3 days in a week for 3 months. So when we take history, it is important for us to understand that this is a phenomena which is occurring for a period of time. Okay, short-term insomnia is something less than 3 months, whereas chronic insomnia is something more than 3 months. So is it common? Why are we talking about it? हम सब तो घोड़े बेच के सो जाते हैं, ऐसा is a common proverb we talk about. But it is found that the prevalence is pretty high, 20 to 30% in infants and toddlers. And some of the reasons is what I mentioned. Apart from medical reasons where a baby can have insomnia, 1/3 of our adolescents are known to have insomnia, and up to 83% in children who have a chronic medical condition, say for instance asthma, say for instance eczema, which disturbs their night sleep, seizures, diabetes, etc., which disturb their sleep. So 83% of children with a chronic medical condition can have insomnia. And the biggest category is children with neurodevelopmental disorders, especially ADHD or autism, and almost 86% in some studies have shown to that they could be insomniac. It's very important to recognize these, because if you do not treat it, it has long-term negative outcomes. So these are some studies from our country where they were just simple surveys. And why I have put both these studies in this page is one is an urban school, and the one which is lower down is a rural school. And there was hardly any difference in the percentages of these sleep disorders. And in the rural school, they use the Bears questionnaire, and I will come to the Bears questionnaire as I go ahead. They found that a significant number, more than 25 to 30% of children had a lot of sleep disorders. And this was another survey which looked at sleep habits and sleep problems in healthy preschoolers. And here also they found that that the sleep training or the sleep hygiene was hardly inculcated in most kids, and many of these preschoolers had problem of sleep disorders. So let's come to the case which was given to me. It's an 8-year-old who's brought by a set of distraught parents as the child resists to sleep and gives multiple excuses. The typical is, I want to use the washroom. Can you tell me one more story? Can I watch one more cartoon on the TV? Can I eat something? I'm very hungry. When the child tells the mother, I'm very hungry, invariably she's going to succumb and she's going to go out and make the child eat something. So multiple excuses to defer sleep. And this is very common. And then finally, the parent gets fed up. We'll give the parent a mobile phone and say, okay, you play a game on this mobile phone while you go to sleep. Okay. So this is the way the child is put to bed. Occasionally, she watches TV in her bedroom, and that many of these children have TV in their bedrooms today. And the parent pacifies himself or herself to say, we have put the TV on low volume so that the child can go to sleep. So that's another way they used to put the child to sleep. As a baby, this child had to be rocked to put to sleep and had multiple awakenings requiring parental support. So first rock to put them to sleep, then rock them again in the middle of the night when they get up, right? And it was difficult. It is now the parents are worried because she has started school. It is difficult to wake her up for the school in the morning, and she's often late. She has to be dragged out of bed. Mom is also a working lady, and she is now fed up because she's herself sleep deprived. And I think many of us would empathize and probably relate with this kind of a story, which happens in many households. So in school, this child is a little sleepy at the start of the school, but she manages her academics. On weekdays, she returns from school at 1:30, naps for 2 hours, and after lunch, then goes out, has studies or whatever, and then is put to bed at 10 p.m., but does not sleep until midnight. Okay. On weekends, gets into bed even later at 11 p.m., takes another hour or two to fall asleep, wakes up at least an hour or two later the subsequent day. So she goes to bed later on weekends, gets up even later in the day. But the weekends, she does not nap in the afternoon because she's fully fresh, because she gets up late. When she goes visiting her grandmom, she finds it very easy to fall asleep. Okay. There is no history of snoring, no leg discomfort, no allergic rhinitis or any chronic medical disease, no history suggestive of parasomnias, movement disorders, or depression in the family, no developmental delay in this child, hyperactivity, any chronic medical disease, or any medications. Her vitals are normal, maintaining SAD syndrome. She's not obese. Systemic examination is normal. Head, face, neck was normal. Malampati classification was 2, tonsils were 1+, and other systems were normal. So what do you derive out of this history? Anyone would like to, what are the pointers in this history which would tell you where we are going? Or it's too pediatric for you, or probably, I don't know. Okay. So I feel insomnia is the causes or resistance to sleep will vary as per age. So infants could have the sleep onset association disorder. They could have medical reasons why they won't sleep, like food allergies, reflux disease, colic, and other medical disease. When you come to a preschooler and a schooler, you have an overlap of etiologies. You could have the sleep onset association disorder. You could have parental separation anxiety. Parents might be wanting to train the kid and put the baby in the next room. There could be inappropriate and prolonged daytime naps. So naps should disappear in kids by the age of between 3 to 5. So daytime napping is actually not required. And many parents feel it's necessary that the child sleeps in the afternoon and will actually force the child to sleep in the afternoon. So these are inappropriate naps which result in insomnia also in the night. Then you have fears, nightmares, infections. And in adolescents, you have a whole set of other problems, including the delayed sleep-wake syndrome, the circadian rhythm disorder, psychiatric conditions, other family school pressure, sleep disordered breathing, etc., which will come in. So how do we approach this child who has come to us who's resisting sleep, and how do we manage? So this is something called as behavioral insomnia of childhood. And behavioral insomnia of childhood could be of two varieties. It could be the limit setting variety, or it could be the sleep association variety. We also have an overlap of these two conditions, and you could have a mixed behavioral insomnia of childhood. Okay. The limit setting is where parents have actually not set limits. So this is a child who made excuses to get into bed, and parents finally gave in. Okay. And then if you do not set consistent limits, and there's no strict bedtime or no good sleep hygiene, and you use gadgets, the blue light coming from your screens, which will further defer sleep. And these are kids who will not want to sleep. The sleep association one is typically seen in younger kids, where they use props like rocking, nursing, or swinging to go to sleep. And since they use this to go to sleep, when they get up in the middle of the night, again, they need it to go back to sleep. They cannot fall asleep on their own. So co-sleeping has been described as a sleep association in the Western literature, but our Indian literature differs from this, and our Indian literature does not find co-sleeping as a hazard to insomnia or sleep disorders, because there are some studies to show actually these kids will sleep even better. Okay, so we need to take a detailed history and examine such children who come to us. The other options that we have, we could look at sleep diaries or actigraphy, and I think Dr. Mahesh Babu has done a very wonderful job, made my task simpler by speaking on actigraphy. And then, of course, we have our gold standard polysomnography. Okay, but the first and foremost is using this simple tool, the Bears questionnaire, to take a detailed history. So if you see here, the Bears questionnaire is again divided by age. The reason why it's divided by age, because as you get older, you need to actually directly ask the child. Of course, you need a caregiver to tell you some history when the child is asleep, but there are some differences as you go by age. So in a child who falls in the 6 to 12 age category, you need to ask the parent and the child, are there any bedtime problems? What is the problem? What is the trouble that your child faces to go to bed? And why does the child not want to sleep? And is there excessive daytime sleepiness? So in children, sometimes you may have hyperactivity and not excessive daytime sleepiness, even if they have not slept in night. You should also ask questions like, does your child feel tired in the night? Does he awaken in the night? Does he have any other reason for awakenings, like sleepwalking or a nightmare? You should ask for regularity or duration of sleep. And you should ask for history suggestive of sleep disordered breathing in the form of gas, snorts, or any apneas which are noted. Apart from this, a detailed history of comorbidities should be taken, any chronic medical disease, depression, ADHD, autism, history of epilepsy, syndromes like the Tourette syndrome, etc. A sleep diary would give you a very good overview of how the child is sleeping, what time the child is getting into bed, what time the child is getting up. It's a simple, inexpensive tool, easy to implement, and it is useful, and you are involving the child. You can ask the child to maintain a sleep diary. And when you are involving a child, then probably the results of your management are definitely better, because the child also then gets, kind of inspired to work towards improving his sleep. There are limitations. There is a subjective element. Somebody might fake some reports. And the total sleep times are actually significantly greater by an average of 1 to 2 hours than actually those if you compare it to an actigraphy recording. So this is how a 2-week sleep diary looks like. And you just mark in an arrow down when the child gets into bed, shade the areas when the child has gone to sleep, and put an arrow up when the child awakens. You can additionally add if any caffeinated drinks were taken or any child did an exercise, so that can be added on into the screen. So this was this child's sleep record, which showed that over weekends she slept late, she got up in the middle of the night and sleep, and was awake for some time. And this is how a sleep diary would look like. Actigraphy, I will skip. I think Dr. Mahesh Babu has covered it. In a child with this kind of a history, where history and probably a sleep diary would tell us most of it, a polysomnography is really not required for coming to a diagnosis. Okay, so in our kid, we had a problem which was going on for more than 6 months. The child had an irregular sleep schedule, improper sleep hygiene, had daytime napping, daytime symptoms. Child was using screens at bedtime. Okay, and it improved after a change of environment. So when she went to her grandmom's house, she was sleeping. Probably there were no gadgets there. Probably her grandmom was strict and putting her to bed. So that also tells you that if the child can otherwise sleep, there is nothing medically wrong with this child, and it can actually sleep early by the change of environment. And there was no history suggestive of any sleep disordered breathing. So how do you manage this child? So we need to look at sleep hygiene. We need to look at behavioral techniques. We need to avoid screens and probably look at pharmacological treatment. And I will go through all of this. So what you need to do for most of these kids, you need to, it's sleep training or sleep hygiene is something which all parents have to be educated about, and it has to be started early. So they have to establish a regular bedtime sleep schedule for children, and it has to be very consistent. Okay, exceptions are only, of course, if you're going out or something like that, but generally it has to be a consistent schedule day on day. The environment of the bedroom should be conducive to sleep. It's advisable not to have gadgets, not to have television in the bedrooms, which are deterrents to sleep. Okay, and the lighting should be appropriate, and it should be an environment which is conducive to sleep. When a mother, if you have a younger child, you're feeding the child, breastfeeding the child, it's again advisable that you put the child to bed, not on the breast. The child should not sleep on the breast. When the child starts becoming drowsy, unlatch the child and put the child to bed. And then the child learns to sleep on his own in the bed. Okay, and I will come to graduated extinction in my subsequent slides. So something like an example of a routine that should be there. Put on your pajamas, use your toilet, go take a shower, brush your teeth. So the child is also sensitized. It is now sleep time. And within 25-30 minutes, read a story and go to bed and sleep. So this has to be like a routine. The bedroom, the bed has not to be used as a playground that he can do some other things. Or if he sees violent TV shows just before he's going to go to bed, he's not going to sleep. So, and the latency, the sleep latency is about 20-25 minutes. So that is what we should aim at, that once the baby gets into bed, the child should be asleep in 20 minutes. So if the child is not sleeping, it is not a good idea to let the child be in bed. So you bring the child into bed during at the time when you think in the next 20 minutes, the child is going to sleep. You can change it as you train the child, but the child should be in bed, and the purpose to be in the bed is only sleeping, and that should be deeply ingrained in the child's mind. So these are the recommendations from any standard textbook, that you must keep a consistent, and you must relax the child. So if the child has a homework pressure or a school pressure, all that should be addressed much before. So the child's mind is at peace when he gets into bed, and you must give positive reinforcement. Don't do this. You're again not sleeping. It's not a correct thing that you tell your child. Wow, today you changed your clothes on time and you are in bed on time. So that is the kind of positive reinforcement you need to give to these kids so they develop a proper sleep hygiene. We need to avoid food and drinks, especially caffeinated drinks at night, so that these kids can sleep better. All right. So this is again a similar thing. And when you do this, the child will learn to fall asleep independently. And therefore you can, again, when you have trained them with a regular schedule on their own, they will learn to fall asleep independently. Okay. Now this is something that we advise our parents to do. This is a method which is called as either a rapid extinction, or it's called crying it out, or the no crying method. So at one end, you can train you can tell the parent, now this child is going to cry, he may want to come out, and he may not want to sleep. You tell the parent, let him cry. You are not going to go back. Even if he cries for half an hour, 1 hour, some children will cry and they will vomit. You go, clean the child, come back, let him cry. But many Indian parents do not buy this. This is my bacha. My mother-in-law will not allow. My neighbor will not allow. They have all possible excuses. But if they follow this technique, within a period of 2 weeks, most children are trained. It's called rapid extinction, and it really, really works. But if a parent says, okay, I will not go. First day he doesn't go for 5 minutes, 10 minutes. The next day he goes. And the third day, again, he will not go. But the fourth day, again, he will give in. When you have this reinforcement, which is inconsistent, you can never train the child. So either you give consistent reinforcement that you will not grow irrespective of the child crying or not, then only you should follow this technique of crying it out. But if you think you're not that firm, then you should probably look at a graduated extinction, because children are actually manipulating you. They're trying to find out how will you succumb. And if they get that information, that input, yes, if I do this, my parent is going to succumb, they're not going to sleep. So this is how the parents have to be. And once you start doing this, the third day, the fourth day is the worst day. They will bring out their worst behavior, because they are also just trying to fight. They're going to put all carefully told to the parents that please do not succumb, and give a consistent reinforcement. So the other way of doing it is graduated extinction. So the first day you say, okay, I'm going to be with you today for 10 minutes, sitting by your side and putting you to sleep. The next day you say it's 5 minutes. You may not even tell, but you may do that for yourself. The third day you sit on the chair, out on the bedside of the bed. The fourth day you say, I'm sitting out. If there's a problem, you call me. So if you gradually do that also, some children you can train. And that probably is, and this one is a no crying method where the response is obviously going to be slower. All right. So this is what I've already explained to you. And this faded bedtime is, you suppose this child is sleeping at 12 o'clock in the night. So you take the child to the bed at 11:30. You do your rituals of your bedtime schedule and you take the child to the bed at 11:30. As per his regular sleep, he's going to sleep at 12. So if you're going to take him at 11:30, he will sleep at 12. After 2-3 days, move to 11, then move to 10:30. While your wake time remains the same. So there will be some sleep restriction in the child, and while you're gradually moving towards a correct time where you want the child to sleep. So you move 15 minutes every 2 to 3 days to the correct time. So this is the faded bedtime. So their parents would say, if my child cries, then will it affect his mind? Will he hate me in the future? They have all such funny questions to ask. So there is a review of 52 studies which have been done on behavioral therapies. These are all called behavioral therapies. And they have found that there are no long-term effects on the mind of the child. And most of these studies showed that these behavioral interventions were effective. And they were not only effective, but they had a long-lasting effect. So you can definitely manage to sleep train your child in this way. And long-term data also, of course, has shown that it has no negative side effects on child's mental health or psychosocial functioning, right? These are studies which definitely show how screen definitely reduce the total sleep time in children and are definitely a no-no, especially before sleep. Now coming to my last part, the pharmacologic drugs which are used for insomnia. In children, we hardly ever use drugs because behavioral therapy alone is most of the times adequate. And medication is only used if this has totally failed. But even if it has failed, it has to be used. Medications have to be used along with behavior therapy. And we have to give an adequate trial because sometimes the parents only succumb and therefore the behavioral therapy is not properly done. Okay. Where we use medication are children who have special needs, medical or psychiatric disorders, neurodevelopmental disorders, ADHD. That's the place where some medications may be used. And we should also, if the child has any other medical disorder like any pain or anxiety, the medication should target that. So that can help the child to go to sleep. Or suppose the child has a restless leg syndrome. So look at giving iron, etc. to target that symptom and so that the child can definitely go to sleep. So these are the list of medications. There's hardly any data for its use in children below the age of 18 years. The only drugs that we use is something like an antihistaminic like diphenhydramine. Occasionally, melatonin is used in children with special needs. So that's the only drugs that we would use in children who have insomnia. Consequences of untreated behavioral insomnia, there are definitely, it impacts their daytime functioning, behavior. They become more irritable through temper tantrums, behavior problems, hyperactivity in the day. And it also affects their academic and neurobehavioral and emotional functioning. This is another kid, 7-year-old, who wakes up screaming, who woke up with screaming spells between 4 to 5 a.m. He's scared. He describes a ghost that he has seen on his room. On parental consoling, he's pacified and goes back to sleep. He's otherwise normal. He remembers the event on the next day and therefore refuses to go to bed and sleep alone. So these are classical nightmares where patient has a memory of that event on the next day. So it is very common in young children, especially in the age of 6 to 12 years. And it is seen in the REM sleep because it's a nightmare, typically seen in the latter third of the sleep. And any scary element could be a monster or ghost, etc. Vocalization, movements, and autonomic symptoms are uncommon because it occurs in the REM sleep. So simple reassurance to the child. What the parent needs to do, you need to make a story out of it. And you need to convert that monster story into a happy ending story. So if you keep doing it for 2 weeks before the child goes to bed, the child is counseled, the nightmares also disappear, and they will not refuse to go to sleep. So this is something which can be done as management of nightmares. The children will again come with refusal of sleep. And my last 1-2 slides. This is an 8-year-old, difficulty in falling asleep since the last 4 months. It started when the child was admitted to a hospital for a fracture. He has no other symptoms. He's otherwise a well child. So this is something called as a psychophysiological insomnia, which we see in children. And it typically occurs in slightly older kids and adolescents. it is because of some anxiety that they develop following an event, a stressful event, and therefore it prevents them from falling asleep. They have heightened physiological and emotional arousal, compromising their ability to sleep. So there is a genetic vulnerability. There are parents, there is the family, there could be a family history of psychiatric disorders, but an acute event is a stress which causes it, and it can be perpetuated with poor sleep hygiene, use of caffeine, use of screens, etc. before sleep time. Treatment is a good sleep hygiene, which I've already highlighted, and to use the bed only for sleep. That's very important. You should not do other things in the bed. You should go there and sleep. And you should go get into bed when you can actually go to sleep. So stimulus control, restricting time in bed to the actual sleep time is sleep restriction, and teaching relaxation techniques to reduce the anxiety. So I would like to conclude by saying that insomnia and its triggers vary according to age and the level of development. History taking is crucial. The Bear's method of history taking gives you a very good overview of the child's sleep problem, and it can help you diagnose causes of insomnia. You should look at comorbidities, recognize them and treat them. And management includes inculcating good sleep hygiene, behavioral techniques, and very, very rarely we use drugs in children. Thank you very much.
Thank you, ma'am, for covering this topic very comprehensively. And Madam has rightly pointed out that the treatment of pediatric insomnia is different from adult insomnia. And I also agree with the ma'am completely. And even in our sitting also, most of the children present with sleep resistance, they already have 2-3 medications, but we usually stop and advise them behavioral therapy and other things. So now is there any queries from the audience or any queries regarding the pediatric insomnia or sleep resistance? Ma'am, as we talk about the adults and when we talk about the comorbid insomnia with sleep apnea, so how common is that in the pediatric population?
The comorbidities?
Yeah.
So
comorbid OSA with insomnia.
OSA and insomnia. So we are seeing a lot of children with obstructive sleep apnea now. In the last 8 to 10 months, post-COVID, the number of viral infections we have seen in kids has skyrocketed. Okay, so this is something called a phenomenon of immune debt that we have seen. So because of recurrent respiratory infections, we are seeing a lot of children with adenoidal hypertrophy. So these are your lymphoid tissues. They have to fight an infection. So the number of kids with adenoid and tonsillar hypertrophy and snoring and obstructive sleep apnea has gone up a lot in the last 1 year, is what I'm seeing. The other reason we see is restless leg syndrome. Iron deficiency is very common, and restless leg syndrome is again a very important reason where the child refuses to get into bed or delays sleep. It may be associated with PLMD, and therefore you may have another problem. Recently I read about a new entity called as restless body syndrome, where the child turns, there are no clear markers to diagnose it, but these are kids who keep on moving in bed. And many parents come and tell us, my child is continuously moving in bed. And we as pediatricians and pediatric pulmonologists have always told them, ये तो होता है, बच्चे घूमते ही रहते हैं. But now it has been described as an entity, and again, the same dopaminergic pathway is implicated, and iron deficiency. So these are all the comorbidities we see with children with insomnia. We do see them very commonly. Actually, history taking on sleep for pediatricians is awareness is very poor. Therefore, it is missed, is what I think. And children with ADHD, autism, hyperactivity is another spectrum we see with problems with sleep.
Thank you, ma'am. So what I wanted to add, ma'am, is that one thing is, madam has rightly pointed out that restless leg syndrome, and many of the children are actually treated by pediatricians as growing pain. So growing pains, everything that treated as growing pain, and sometimes as benign hypermobility syndrome. But this restless leg syndrome can be usually actually treated by oral iron supplementation. Now, adults use sometimes pramipexole, but I think Mandri madam is using. But in pediatrics, we don't usually use pramipexole. And the other thing is, when you are using actigraphy for pediatrics, as in the previous session I also pointed out, we don't rely on the actigraphy pulse oximeter. We try to do it in the hospital setting. We only rely on the sleep, light sleep, deep sleep, that pattern on the actigraph watch. and we do our pulse oximetry and continuous heart rate and respiratory monitoring. And whenever possible, we also have a capnography. And because the CO2 is the most important rather than the oxygen. So people rely on the 3% oxygen saturation deep or less than 90%, but it is the CO2 retention which causes the headache and these learning problems and all these things. So if possible also we should include a capnography, but this actigraphy, this is more challenging in pediatrics. And sometimes somebody is asking how to put the watch in a 2-year-old. We put it on the ankle sometimes. And most importantly, the actigraph problem is whenever the child is going to sleep, it will not detect the sleep onset latency. Whenever the child is stopped, it means the child will detect there is asleep, but actually it might be insomnia.